This lecture provides a brief overview of the lateral flow assays that can be used to detect SARS CoV2 antibodies and thus signify a potential past infection by the virus. And so in order to get into that, I'll first talk about the kinetics of antibody production as pictured by this graph. On the y-axis, you see antibody level. On the x-axis, you see days following initial infection of the two main kinds of bloodborne antibody, IgM and IgG. So at some point after the initial infection, these data are not absolute. They change from individual to individual and disease to disease. So it's not a consistent event. The incubation period here is typified by a lack of symptoms, but the immune system is being primed essentially to produce antibodies against the specific invader. So usually around 2 weeks, we initiate the production of immunoglobulin M or IgM, which is the first antibody on the scene typically. IgM rapidly increases and then gives way to production of the more specific and stronger neutralizing antibody IgG, as you see here. And then eventually the IgG levels will taper off after a few months typically. After a certain amount of time, however, your body will produce immunological memory, which means that we don't rely on the circulating antibodies anymore to fight these infections. We rely on a memory response. So when you're reinfected some years later, or even months later, or whatever, the memory response kicks in relatively quickly. In that case, we get less of the IgM because it's not as important, and a faster, more intense IgG response upon secondary exposure to a particular antigen. So the way this lateral flow assay works then is through this mechanism that's illustrated here. The first thing that we do is we apply blood to these sample wells, and this can come from a lancet or a finger prick of some kind. And so in this particular case, the blood is applied, and then a drop of buffer is applied, and that pushes the blood and buffer combination over a conjugation pad. So if there are any antibodies to SARS CoV2 in your blood, they will bind to the SARS CoV2 antigens, which in turn are bound to gold, in this conjugation pad, and will continue moving until they're grabbed onto by the anti-human antibodies that exist here. And that will cause precipitation of the antibodies in your blood and the antigen in the conjugation pad bound to gold here to make a band. Again, there's anti-human antibodies fixed in this region here that will grab onto the antibodies and antigen complexes and form a band here if you're positive for IgG and a band here if you're positive for IgM. There's a control built into this as well, and that is the rabbit antibody gold that's in the conjugation pad as well. So these rabbit antibodies bound to gold will be pushed by the buffer past this because these are anti-human antibodies and they won't attach to these rabbit antibodies. They'll move past that to here where there is anti-rabbit antibodies that will grab them, causing the gold complex to precipitate and making that band that you see. So if either of these are blank, then we can't rely on this test, and the test results are inconclusive and unreliable. So you must have bands here, and if you don't have any bands here, then obviously it's negative. Here's a little bit more of an overview of the results. In this particular case, you have the control well, the rabbit band is present in all of these, so they're all reliable. In this assay, there's no IgG and no IgM. I should point out that this particular test does IgG and IgM in the same cassette, in the same lane rather, whereas in this particular assay, there's two separate lanes in this cassette. So this indicates that there's, again, no infection or not enough detectable antibodies, meaning that it could be too long after or too soon before the infection initiated. And so as a result of that, the antibodies either never existed because you weren't infected, or they dissipated because the timing was too long. If you get a result like this, where IgM is negative and IgG is positive, as long as the control is positive, we can conclude that this is a previous infection. Again, it's not surprising. If IgM is negative, and you might still have IgG present. This result indicates a more recent infection, again, because you have IgM but no IgG. Your body has yet to turn over production from M to G. Again, as long as control is positive, this is a useful and reliable test. And then if all three are positive, then that also may signify a relatively recent infection.
So here I am using a sterile razor blade, not exactly the way to do this because I don't have a lancet, and I'm trying to slash myself to get some blood. Now I had to massage the finger a little bit to push the blood to the surface. And I'm going to use a micropipette to draw out about 20 microliters of blood that I can apply to the sample wells of the cassette in front of me. And that little dropper bottle contains the buffer. It's going to push my blood sample across the conjugation pad. Let's draw a second sample for the IgG well. So IgG and IgM are just two kinds of antibodies that you would produce. Typically IgM comes first, and then your body produces the more specific IgG, usually after a week or so following initial infection.
And here are the results of the lateral flow assay. So as you can see, the control lanes both have bands, suggesting that the results are reliable. IgM is not present, as indicated by the lack of band here, but IgG is present, again, suggesting that this faint band is a positive for anti-SARS CoV2 IgG antibody. This assay was conducted about 3.5 to 4 months after my symptoms, my COVID-19 symptoms, and therefore it's not surprising that the IgG is virtually gone and the IgM is completely gone, again suggesting a result sort of like this one here.